and you can get started as well whenever you're ready.
Okay. Thank you so much for having me, guys. So, so my plan is to do like a series of lectures about liver problem, including outpatient, patient, and ICU patients. It would be interactive, so hopefully you'll like it. So as I mentioned, our like my objectives would be to have some skills to approach outpatient and patient either in the floors or ICU with LFTs abnormalities, some tips and tricks in initial workup and management, and we'll aim for interactive discussion. So first of all, I have like 4 short cases, just like for our first take-home message. Case 1, who wants to do it first? We will do it all together. There is no like, we won't judge anyone, and we'll teach from each other.
I can start.
Okay.
Hey, Nour.
Hey.
22-year-old physically active male, no significant past medical history, presents as a new patient in clinic for annual exam, asymptomatic, normal exam except jaundice, and CMP positive or remarkable for ALT of 20, AST 25, total BILI 2.3, ALK of 100.
Okay. So what's the abnormal thing in his CMP?
The bilirubin.
Okay. So total bilirubin, right?
Total bilirubin. So
what do you want to do next?
We would need direct bilirubin and direct and indirect bilirubin.
Okay. So here's the rest of his LFTs.
You want me to read them?
Yeah, I mean, or like what do you think? Like, so his direct bilirubin is normal, right?
Yeah.
Total bilirubin is 2.6, so it's elevated.
So it's indirect.
Yeah.
Hyperbilirubinemia.
So what?
Normal LDH and haptoglobin with a 1% reticulocyte.
Okay. So when you have a patient with elevated indirect bilirubin, what would you think and what would you order for him?
So you think about hemolysis and I'm just thinking that, but then the reticulocyte count would be elevated.
Yeah. So in this case, his hemoglobin is normal, LDH normal, and haptoglobin is normal with reticulocyte in the normal range. So he doesn't have hemolysis, right?
Mm-hmm.
So we need to figure out something else. So just like to go through like where we get that bilirubin from. So, you know, guys, like whenever you had a red blood cell near end of life, which is around like 120 days, it will eaten by a macrophage in the reticuloendothelial system, which includes the spleen and lymph nodes, and it will break down to globin and heme. Heme in turn like would convert it into protoporphyrin and the unconjugated bilirubin, which is the indirect bilirubin. So this like molecule is like lipid soluble, so it needs like a transfer in the blood to go to the liver, which is the albumin. You can like imagine it as a taxi or cab that would take the unconjugated bilirubin to the to the liver, where it gets a matchmaker, and it converted it from single bilirubin to like a couple bilirubin, and then secreted to the bile. So you have here the red cell, then indirect bilirubin, which is converted to direct and then gets secreted. So what happened is that whenever you had like a hemolysis, you will have a lot of red blood cells were broken down and eaten by macrophages, and you will have a lot of conjugated bilirubin, which is too much for the hepatocell to handle, and then you will get elevated indirect bilirubin, right? But this is not the only mechanism that you will have indirect bilirubinемia, hyperbilirubinemia. That is a process that it would take the indirect bilirubin inside the hepatocell, which is the uptake, and then conjugation with the enzyme, and then secreting. All these like processes need energy and need like need a like an intact process. So the uptake can be affected by some medications, some like diseases, as well as conjugation with the enzyme that usually we have all like normal level that is enough to match make all the single guys into a couple. But sometimes we have like some genetic orders, such as Gilbert disease, which usually in young patients usually have family history of like someone with elevated indirect bilirubin, and we will have like he will have elevated hyperbilirubinemia, and if he has like any stress like infection, starvation, fasting, sometimes like excessive exercises. So for such patient, most likely he doesn't have hemolysis, because we saw that his hemoglobin is normal and the hemolytic like workup was negative, and the rest of LFTs were normal, which make it unlikely to have a liver like dysfunction. So most likely it's either a problem with the uptake, which might be related to some medication, which he's not taking any, or low enzyme. It's usually a benign condition that doesn't need anything, just like monitoring and just like prophylaxis by like doing like a little of exercise or not fasting. So this guy has hyperbilirubinemia, but it's indirect. Okay. Second case, who want to go for it?
So Neha, do you want to go?
Sure. So an 18-year-old male with no significant past medical history presenting to the ED with acute onset fatigue, yellowish discoloration of skin, sclera, and dark urine. Of note, he was diagnosed with UTI 4 days ago and received 3 days of antibiotics that he doesn't remember the name of. Physical examination, remarkable for jaundice, otherwise normal. His CMP was remarkable for his T-bill is also, total bilirubin is elevated to 6.5.
So what's the abnormality here?
The total bilirubin is elevated in the CMP, so that's abnormal.
And the AST.
AST is elevated to 50, ALT is normal.
Okay, what's next?
In this again, we'll see if the direct bili, what's the ratio of the direct and indirect bili.
Okay, so in this case, he's also on the indirect, like the elevation in the indirect bili. What do you do next? So we discussed that elevated indirect bilirubin would be from hemolysis or from like some medication that can like cause impairment in the uptake or coagulation of the indirect to direct bilirubin, right? So to rule out hemolysis, what would you order for this patient?
We can do an haptoglobin.
And in the chat, we have a little bit of participation. Jonathan and Lenise would want to get us G6PD. Raj is saying check LDH and retic, probably in line with what Neha was saying, but I think she mentioned hapto.
Yep. So this patient hemoglobin was 9.5 normocytic. White count platelets were normal. LDH was elevated. Haptoglobin low. And corrected reticulocyte was high with peripheral blood smear, white cells, and Heinz bodies. And like as you mentioned, that is like he might be G6PD because of the peripheral blood smear showed white cells, but sometimes when we do labs for G6PD during the acute hemolytic episode, it would be normal. So we can wait like 2 to 3 months to do it. But I just like my point from this case that elevated bilirubin might be not direct, so it's not be related to the liver. So we need to get direct bilirubin to see if it's like if the elevation is direct or indirect. Then if it's indirect, we need to rule out hemolysis for such patients. And we discussed about that when there is like hemolysis, there is a lot of like indirect bilirubin that the hepatocyte can't manage. So it will like just go backed up in the blood and cause jaundice and elevated indirect bilirubin. Okay, so like just to recap, we have unconjugated hyperbilirubinemia. It's either increased bilirubin production, increased bilirubin production by hemolysis, or if we have like extravasation of blood to the tissue, like large hematomas. Also impaired hepatic bilirubin uptake, which might be in heart failure, some shunts that overcome the liver, and medications. There is also impaired bilirubin conjugation, such as Gilbert disease, Crigler-Najjar, and there is like hypothyroidism, cirrhosis, and chronic hepatitis. And there is like the elevation in conjugated hyperbilirubinemia, which might be either from obstruction of the biliary tree or from dysfunction of the hepatocyte. We'll talk more about this later on. Case 3, who would go for it?
So Salvador, do you want to go?
Yeah, of course. So a 35-year-old housewife, female, with no significant past medical history, presenting to the clinic as a new patient visit to establish care. On review of system, she reported general mild ache. Vital signs and exam were unremarkable. Her CMP is remarkable for ALT of 23, AST of 25, total bilirubin 0.3, and ALP cost of 250. So I think in this case, the ALP cost is positive finding.
Okay, so what do you want to do next?
So in this case, you can have like elevation of ALP cost from biliary pathologies, but also from non-biliary diseases. I think like basic workup initially, and I think it's had like GT to differentiate it. But I don't see like a cholestatic pattern here, so I would start like with CBC, like, and then see the GT.
Okay. So yeah, exactly as you mentioned that she has elevation in the ALK fast, but for now we don't know if it's hepatic versus extrahepatic because it might be secreted from other sources. So we need to figure out if it's hepatic or no. And gamma GT would help with that.
No
So
problem. I have to get the GGT. Yeah.
Yeah. So gamma GT is normal for this patient. That's mean that most likely it's extrahepatic. And as you know, guys, like elevation of ALK fast, it might be hepatic, intrahepatic, or extrahepatic cholestasis, but we also need to think about non-hepatic causes, including like bone disease, from placenta and pregnant women, from the intestine, kidney, and some malignancies. So it might be physiologic in children and adolescents, third trimester of pregnancy due to like placenta influx, and sometimes patient with like blood type or B would have influx of ALK fast after a fatty meal. And also like bone diseases, including osteomalacia, budget, hyperparathyroidism, and hypothyroidism, where there is like high bone turnover. Also, it was found in diabetes, some cases of diabetes, gastric ulcer, and there is some like extrahepatic tumors. So for this patient, she's not currently or recently pregnant, and she's up to date on her like cancer screening. The rest of her labs were remarkable for low calcium, low phos, and her vitamin D was so low. She ended up having secondary parathyroidism due to vitamin D deficiency, which can cause elevated ALK phos and low calcium phos. Okay, last case, who want to do it?
So, Sarah, you want to take over?
Okay, so it's a 31-year-old male presenting to the ED with altered mental status. On exam, he's drowsy, difficult to awake, moaning whenever touched. Otherwise, normal heart, lung, and abdomen exam. Found to have polysubstance intoxications, including cocaine, benzos, and cannabinoids. CMP was remarkable for ALT of 300, AST of 1,300, T-billy of 0.4, and ALK of 100. So abnormal here is the ALT, AST, and I think the ALK phos is a little high. I would probably say get a right upper quadrant ultrasound, but also like further lab work to see what else is going on.
Okay. Why do you think his
alcohol level too?
Okay. Well, why do you think his AST is more than ALT?
It might be alcohol related.
Okay. Any other thoughts?
Maybe any of the other medications he's on, or like the drugs that he's taking.
Okay. So you're right, like we usually sometimes we can suspect in like polysubstance abuse patient that he might have like drinking alcohol, and because like alcoholic hepatitis, right? But in general, like in alcoholic hepatitis, we would have like ALT, AST less than 500, and you're right that AST to ALT ratio would be more than 2, but like it's really rare to have AST like to the 1300 as for this patient. And also you need to keep in mind that AST is really not 100% like specific to the liver. It can be elevated in different different pathology as well. So like the rest of his workup, CBC, he has like white count, his LDH is very elevated, he has acute kidney injury, and his CK was 70,000, and his UA was positive for hemoglobin. As I mentioned, his UDOX is positive for cocaine, benzo, and cannabinoids, and his alcohol level is normal, acetaminophen normal, salicylated normal, and they ordered like for him some like acute viral hepatitis 1, which was negative. But like as you can see, like he's a polysubstance abuse patient. He is like positive for cocaine. That is like a markers for like a muscle injury, including the very elevated CK, positive hemoglobin in his urine as well. And he has like clinically myalgia as well. So just like to keep in mind, guys, that AST can be found in the liver, but also can be found in muscles, kidney, heart, and brain, and also elevated in hemolysis. And ALT is more specific to the liver, but it can also be elevated in severe muscle injuries, such as this patient. And also just to keep in mind that ALT has a longer half-life than AST. So in general, what's get better is AST first, then ALT, then ALK phos. ALK phos would lag behind all of them. It might take like weeks. So this patient ended up to having rhabdomyolysis due to cocaine intoxication. So just in general for these like prior 4 cases, I just like want you guys to think out of the box. Just like don't whenever you had a abnormal in the LFTs, just like think that it might be related to liver, but also think out of the box that it might be not related to liver. So just broaden your differential and order further workup before blaming the liver. All the cases that we got, first patient with indirect bilirubin and found to have Gilbert. The second one, elevated indirect bilirubin, found to have hemolysis. Third lady, elevated ALK-FAS, found to have osteomalacia, like bone-related disease. And the fourth one, elevated AST more than ALT and found to have rhabdomyolysis. So just keep in mind to think about other like not liver related problem causing abnormal LFTs. So this is the end of part 1. Take a breather. Any questions for the past 4 cases? Okay. So next is our hepatology part, which is like, I'll start with outpatient for now. We'll do 4 cases if we can. If we can't, like, we'll do whatever time allowed us. Just before starting the cases, I just like want you to get some tips of how to differentiate liver injury. So in general, we divided to hepatocellular versus cholestatic based on ALT ALK-FAS ratio. So that is, if you open up your mid-calc, there is something called R factor, and you can, it's calculate the ratio between ALT and ALK-FAS. So if it's like more than 5, it's most likely hepatocellular injury. Usually there is like a prominent elevation in the ALT-AST. If it's between 2 and 5, there is mixed injury. And if there is, if it's less than 2, it's cholestatic injury. Usually you will have ALK-FAS more than 2 times upper normal limits. The next thing is to differentiate, like just stratify the severity of liver injury, which is so important. So usually we'll say it's like severe liver injury if there is like coagulopathy, which is INR more than 1.5. That's mean there is really bad impairment of liver, like function, and also encephalopathy. So any patient with abnormal liver function who has like INR more than 1.5 plus minus encephalopathy, he needs like really like a high level of care and urgent like liver consult or like even liver transplantation consult. Next would be degree of cholestatic injury. So moderate if ALK-FAS is less than 4 upper normal limits, a marked elevation would be more or like equal to 4 times upper normal limits. Degree of hepatocellular injury would be very mild, less than 5 times, mild to moderate 5 to 15, and marked elevation more than 15 times of upper normal limits. Just like the normal reference, like normal values, it's usually different between male and female, sometimes based on age and body mass index. But for now, we'll take it 6 related, usually in male more than females in all levels. Okay, so just like before starting with the cases as well, I just like wanna make sure, guys, that you ask like questions related that can guide you regarding what type of injury such patient might have. So for each patient with abnormal liver function, you need to ask about current or recent medications, current or recent herbal supplementation, occupational environment or environmental like toxic exposure, history of IV drug use, history of high-risk sexual activity, history of blood transfusion, especially before 1990, and history of like tattoos in places that are not like maybe like follow the rules. Personal family history of liver disease, personal family history of autoimmune disease, history of metabolic syndrome, alcohol consumption, weight, and BMI. So any patient who came into the clinic, or you have it in the as an inpatient, you need to focus on these questions just to guide you guys for what might be the reason for his or her liver dysfunction. Okay, so now we'll start with hepatology outpatient cases. Who want to go with the first one?
Darren, do you want to go?
Hold on one second, yeah. 55-year-old with history of high blood pressure, high cholesterol, smoking, COPD. He's presented to the clinic for physical and medication refill. Reported no complaints, physical exam unremarkable. LFTs remarkable for ALT/STs of 65, T-billy of 0.4, direct billy of 0.2, alk phos of 90, INR of 1.1, albumin of 4. Of note, the LFTs 1 year ago was unremarkable. What do you want to do next?
So what type of injury does he have?
I'm sorry?
What type of injury? Is it like hepatocellular or like cholestatic?
Oh yeah, so it's a hepatocellular, it looks like, because it looks like the T-billy is normal, so it doesn't look like any cholestatic disease.
Yeah, so it's cholestatic versus hepatocellular based on the alk phos and ALT. So his alk
Oh yeah,
phos,
alk phos and AST.
so and he has like very mild elevation in his ALT and AST. How about the severity? So that the severity based on INR and mental status. So what do you think?
So it looks like the R factor, or the R factor is 2.3, but it looks like his INR is okay. The mental status is fine as well too, right? So it's not as severity, I would say, is
It's not severe. Okay, so it's hepatocellular, it's very mild, and it's not like as acute or severe liver injury. So what do you want to ask the patient? We can't hear you.
sorry, just so from the previous slide, I think there's more about the history that you have to go into as well. So you'd have to ask about sexual history as well. You'd have to ask about, how much they drank as well. So social history, sexual history, those are very important things to getting a better idea of what is causing this hepatic injury.
Okay. So, so his current and recent medications, he's on amlodipine, he's on atorvastatin 40, which was started 6 months ago. There is no herbal supplementation, and he's post-officer. There is no history of IV drug use, sexual activity, high-risk sexual activity, blood transfusion, or tattoos. No personal and family history of liver disease or autoimmune disease, and his alcohol consumption is less than 5 per week. His BMI is 24.1. And his further workup, hemoglobin A1C was normal, and lipid panel was like he has LDL 130. His viral hepatitis panel was normal, like negative. What do you think is going on with this patient?
So I think just immediately there's no large risk factors for like hepatitis, but I think the most obvious thing that I see is probably the statins that are probably causing some sort of injury that's going on.
Yeah. Would you stop his statin?
I feel like someone that stops statins has to have some sort of like symptomatic, approach of like muscle cramps or so. Usually that's my biggest indication for stopping statins.
So that's for like myalgia or like
Right.
muscle injury. How about liver injury?
I would say probably yes. Well, I mean, I would say you have to outweigh the benefits and risks, right? So his LDL is
130.
130, right? So I would take a wild guess and say yes, stop the statin.
Okay. Okay. So, so as you mentioned, it's hepatocellular, very mild and not severe. So, and just like in such cases, we need to drug-induced liver injury, as you mentioned, chronic viral hepatitis, it's negative. Occupational, he's like post officer, is not like in exposure to any toxins. Autoimmune hepatitis, I mean, given his age, no family history of autoimmune disease, and normal LFTs before, and just like the temporally of his abnormal LFTs after 6 months of statin, like make it a little bit questionable. NAFLD, like non-alcoholic fatty liver disease, he's not obese. I mean, he has hyperlipidemia, but I maybe he has like some component, but like also recent LFTs was negative before starting the statin. Genetic disorders, I mean, Wilson disease, no, because usually family history and usually younger patient. Hemochromatosis might be, but like he has normal LFTs before. It doesn't have family history of hemochromatosis. I mean, we can test it for that, but maybe if he had like consistent elevation of LFTs, we might. Doesn't have a history of heart failure, and it doesn't like he's like up to date with his cancer screening, and there is no other like symptoms. So we repeated the LFTs in 3 to 6 months, and it was normal, but we didn't stop the statin. So in general, for the DILI, which is drug-induced liver injury, it might be hepatocellular, cholestatic, or mixed. And there is like other rare like steatosis. Sometimes some medication can cause fibrosis or granulation. Just like to take it at home message, liver, like drug-induced liver injury might be dose dependent or not dose dependent. There is like direct hepatotoxicity, which is usually with medication that have a like specific latent time, and it's like known to cause liver injury, and it's usually dose dependent. But there is another like type, which is idiosyncratic, which is usually immune mediated, and usually you don't have like fixed latency before causing that and causing the injury, and it's usually not dose dependent. Some medication with one dose can cause liver injury, and it's like with variable latency time. So, and like, you know, guys, the most common drug implicated in drug-induced liver injury is in the US is acetaminophen, and then the antibiotics, and also anti-epileptics medications. In regard to the statin-related drug-induced liver injury, it's usually occurring after 3 to 6 months, but like some study mentioned up to 10 years, and it's usually dose-dependent and usually transient. And the pattern of injury usually hepatotoxic, like hepatocellular, and we don't usually do a liver function test in patient who we're planning to start statin on, because most cases are transient and it's mild. So we don't usually routinely test patient for like liver function test before starting it. And just like if the patient have symptomatic liver injury, which is like fatigue, nausea, vomiting, jaundice, abdominal pain, and ALT more than 3, then at that point we need to stop it. Or if it's asymptomatic with more than 5 upper normal limits, we need to stop it. So only these two, either ALT more than 5 times upper normal limits or more than 3 times upper normal limit, but with symptoms. Otherwise, there is no need to stop it, just like monitor the patient, and most likely it will be transient and like resolved by itself. And just like also another fact that in patient with chronic liver disease, pravastatin seem to be safer than the rest of the statin. So as I mentioned, for such patient, he's asymptomatic. He has a LFT and ALT, AST elevation less than 5 times. We'll check in 3 to 6 months. If it's still elevated, we need to check for other like possible diseases, just such as like hemochromatosis or other genetic diseases. But for now, just like repeats in 3 to 6 months and decide what the next step based on that. And there is like a website called LiverTalks. Just like if you suspect any drug-induced liver injury, just like open this site and you will see if there is possibility for any medication to cause liver injury, what type of liver injury such medication can cause, and what you need to do next is like this, to sub-medication, to monitor, to whatever. Like it's really a good website for drug-induced liver injury. Next case. Who want to do it?
So Lenise, do you want to go?
Sure. This is a 57-year-old female with past medical history of hypertension, hyperlipidemia, diabetes, obesity class 2, presenting to the clinic for physical and medication refill exam, remarkable for liver span of 20 centimeters, no signs of chronic liver disease. Of note, she has been having very mild elevation of ALT and AST for the past few years. Her current liver functions were remarkable for ALT 97, AST 85, total bili 0.4, direct bilirubin 0.2, alphos 90, INR 11, albumin 4.
Okay, INR 1.1.
Sorry?
INR 1.1.
Oh, 1.1, sorry, is
Right.
okay, okay.
Okay, so what type of liver injury does this patient have?
I think it's hepatocellular.
Okay, is it
Yes,
severe or?
it's not severe.
Okay,
The ALT, AST are like slightly elevated. Yeah, it's not severe.
okay, what do you want to do next? Or what do you want to ask
I
next?
would like, well, I would like to do an ultrasound of the liver because she has obesity class 2, mild elevations of ALT, AST for the past few years. Maybe she has some hepatic steatosis going on. So I will do an ultrasound.
Okay, do you want to do any other labs for her?
Maybe we can do some autoimmune hepatic panel or just to rule out any autoimmune disease. Also, maybe we can do hepatitis as well. Lipid panel. Yeah.
Okay, sounds good. So just like for other information that is really important for liver injury. So she's on lisinopril, hydrochlorothiazide, she's on atorvastatin 40 and metformin. No reason recurrent herbal supplementation. She's a housewife. No history of IV drug use, high risk sexual activity or tattoos, no family or personal history of liver disease, no personal family history of autoimmune disease, no alcohol consumption, and her BMI 37.3. Her A1C was 12, lipid panel was all over the place as well, elevated LDL, low HDL, and elevated triglyceride. So as you mentioned, it's a hepatocellular mild injury. It's like between, it was like about 5 upper normal limits, and it's not severe. She's on statin, but like she's been having this injury for a few days now, for a few years now. So we need to think about other stuff first before like blaming a statin. We need to figure out if she has like chronic hepatitis B or C. There is no occupational exposure for her. Autoimmune is a good idea. And NAFLD, I mean, she has hyperlipidemia, she has uncontrolled diabetes, her hemoglobin A1C is 12, she has obesity, class 2. So all these like risk factor for NAFLD. Wilson, she's too old for Wilson. Hemochromatosis might. And she doesn't have like, and also for alpha fetoprotein, no family history, no clinical, like no clinical signs of heart failure, and she's up to date on her cancer screening. So the rest of labs, hepatitis B negative, C negative, and for hemochromatosis, we usually order transferrin saturation ferritin, which are like less than the like cutoff for hemochromatosis. Usually transferrin saturation more than 45% in hemochromatosis. CH is normal and the autoimmune workup was negative. We did the ultrasound. So this is normal. Usually the kidney and liver would have the same echogenicity, but look at this. So like the liver is like more whitish in compared to the echogenicity of the kidney. So this is one of the signs of steatosis. And also you can see that you can approach like the liver, it's at the side of like the kidney, but here, look how much is like, is huge. So she has like hepatomegaly, even on exam, it's like the liver span was 20, which is the normal up to 12 to 14. And she has steatosis, and also she got ultrasound elastogram, which showed steatosis grade 3. So this patient ended up having like non-alcoholic fatty liver disease. So just like some facts about non-alcoholic fatty liver disease, usually AST to ALT ratio less than 1, so ALT would be more than AST, and they usually 2 to 5 abnormal limits. You won't find like more than like 300 with NAFLDs. Just like think about other stuff if you have more than 300 ALT or AST. Usual patient would start with steatosis and then steatohepatitis, which is this patient has. So steatosis is only like clinical and ultrasound diagnosis, which is like the liver would be large and fatty, which is like whitish or grayish in the ultrasound, but the ALT-AST would be normal. When the patient has elevated ALT and AST, that means she's having hepatitis due to the fat accumulation in the liver. The next stage would be fibrosis and then cirrhosis. And usually the diagnosis would be by exclusion. And sometimes we need biopsy for some patients. We need to exclude significant, like, because we can see steatosis in other liver injury, including alcoholic liver injury, sometimes hepatitis C, and DLH is like drug-induced liver injury due to amiodarone, methotrexate, valproate, and steroids. And also we need to exclude other like reason for chronic liver injury, including genetic, autoimmune, and viral. Sometimes we do liver biopsy for patients who have stigmata of chronic liver disease or cirrhosis. This patient opts not to do it. And just like regarding management, it's like weight loss, the most important thing, physical activity, optimal control of her diabetes and hyperlipidemia, just like get rid of other possible assaults on the liver, including no alcohol, vaccination against Hep B and C, and also consider bariatric surgery. The problem with NAFLD that the medication usually given only for patient with biopsy proven NASH. And there is no rule for metformin for such patients. Any questions for now?
Why is it that you only give the treatments to biopsy proven? Is there like significant risk with them?
I'm not sure like 100%, but like for example, bioglitazone, like you need to like risk versus benefits for some medications. But it like studies didn't show really like I'm not sure why it's only like for biopsy proven. Maybe like the fact that they can follow up on like what happened after getting the medication for a certain amount of time, and then they need another biopsy for seeing if the patient get improved or no. But it's limited only for such patient, and vitamin E only for non-diabetic, which is like really most patients with like steatosis and like NAFLD have some type of like glucose intolerance or like diabetes. So it's, but it's like what I've been on liver clinic, and they usually just like send a patient for bariatric surgery, which is like the most effective way to treat steatosis or steatohepatitis in such patient. But like medication is not really, I've never seen anyone like prescribing such medication with benefits. So we'll do the last case. We want to do it?
Sure, I think we still have a few minutes for one last case to go over. Jonathan, do you want to go?
Sure. 35 male, no past medical history, presents to clinic for new patient. Physical exam is unremarkable, no stigmata of chronic liver disease. Current liver functions are remarkable for ALT is 260, ST 200, T-Billy 1.2, direct 0.9, alk-phos 140, INR 1.1, and albumin 4.
So what type of liver injury does this patient have?
So I think it's, I'd have to do the math, maybe mixed. I'm not sure though. Looks like it's mixed.
Okay.
I'd have to calculate it. And yeah.
Severe or no?
Severe, so the INR is 1.1 and patient is not encephalopathic, so it's not severe.
Okay. So what do you want to do next?
So I'd probably, I'd probably just want to get more history on the patient first, and sort of all the things we've been discussing.
Okay.
And I'd probably, send like the workup, the hepatitis panel, all the stuff that we sent before.
Okay. So for this patient, the only thing that he has a family history of cirrhosis in his father at age 60, but he doesn't know the etiology. Otherwise, alcohol consumption less than 7, his BMI is 24.5, no medications, no high risk IV drug user or like sexual activity. And his labs, so this is hepatocellular, moderate, and not severe. His lab's remarkable for Hep B antigen positive. Otherwise, the rest of the labs, including autoimmune, Wilson, and alpha-1 antitrypsin were negative. So the next step after having reactive S antigen and core antibodies would be to send for E antigen, which was positive, and DNA was also 55,000 units per liter, and his ultrasound just mild hepatomegaly, otherwise unremarkable. So what do you want to do with this patient? Or what do you think is like stage of like Hep B is this?
I have no idea what stage it is.
Okay, so he has elevation of his ALT, like he has active necrosis, right? He has active like inflammation now because he has like elevation in ALT and AST. He has positive E antigen and he has positive DNA. So this is the new like classification of Hep B. We used to have like other phases of like terminology, but it's not used anymore. It's only now hepatitis versus infection. So hepatitis means that you have elevated ALT, AST, and infection means that you have the virus, but it's not active. It's like not causing necrosis or inflammation, which like means that ALT, AST are normal. And we usually treat only the patient who has active necrosis or inflammation, which have hepatitis. And usually classify these patients into HPE antigen positive or negative. So, and the difference between those two is like just mutation that can cause the negativity in the HPE antigen. So usually that when we treat in patient who has a positive Hep B antigen, we usually treat if they have signs of active inflammation, which means the ALT more than 2 upper normal limits with PCR more than 20,000. And we usually treat until the HPE antigen converted into positive antibodies. For patient with HPE antigen negative, we usually treat if the PCR is more than 2,000 and the ALT is more than 2 upper normal limits. And usually these patients continue indefinite. But it's different for patient with cirrhosis. So we will treat in like regard of their ALT or HB antigen status. And it would be different if it's like compensating versus decompensating. So for every patient with like decompensated liver disease, we treat in regardless of everything. And for compensated, they need to have PCR more than 2,000 and they need to be treated indefinite. And just like last point, that just make sure for every patient who have hepatitis B to test it for HIV and Hep C as well, because the treatment would be different and the order of treatment would be different. Usually Hep C suppress hepatitis B. So if you treat Hep C without treating Hep B, it would be reactivated. So just keep this in mind. And you need to treat both of them as well. For the HIV patient, you need to pick up like a medication that can cover both of HIV and B and HPV, including tenofovir. Last point is just tips when you screen for HCC for such patient. Like all patients who have cirrhosis need to be screened for HCC with imaging every 6 months. But patients without cirrhosis, they need to be screened if they are Asian, more than 40, Asian men or more than 40, Asian women more than 50, anyone with first degree family history of HCC, or co-infection with Hep D, or African Americans at any age need to be screened for HCC every 6 months with imaging, with and without alpha-fetoprotein. This is it for today. Any questions?